We'll go ahead and get started. My name is James, and I'm a PA. I've got a short intro I'm going to play in a second. For right now, also introduce you to Jordan. Jordan is a PA student that I've been working with for, I don't know, is it most of this year, I guess.
Yeah.
We started working out with Jordan on what she'd need to do to be a competitive applicant, and then helped her with her statement and her mock interview. And then which program did you first get into?
Toro.
Okay. And you had an interview with Pace up in New York, and then you've got one pending with St. John,
Mm-hmm.
and then we're just waiting to hear on a couple of other schools too, right? But
Yeah.
definitely going to be a PA.
Mm-hmm.
Okay. So I won't delay this any further. I'm going to do a real quick intro.
My name is James Kimber, and I am a physician assistant. I did my undergraduate work at George Washington University, and I went to Stanford Medical School for my PA training. I come from a family of medicine, actually Navy medicine. My grandfather was a Navy doctor during World War II, as well as my father was also a Navy doctor during World War II. So it probably seemed inevitable that I would go into medicine, but actually it's anything but that. I did think growing up, I did want to follow in my father and grandfather's footsteps. So I did join the Navy, but my goal was to become a Navy pilot. Unfortunately, the Navy had other ideas for me. They told me that I was colorblind and said, nope, you can't fly, but they told me you can go into the medical field. This was a great delight to my parents, although it wasn't something I'd ever considered. So I joined the Navy as a hospital corpsman, which is a medic, sort of like an EMT. As a hospital corpsman, our role is to just manage basic illnesses, treat minor injuries, do suturing. I could start IVs. I could even put in a chest tube or intubate a patient. So as I continued in healthcare, I decided I actually kind of like this. And I went through some advanced training where ultimately I was the senior medical representative on board a ship. So I did that for several years until someone came up and said, why don't you just become a PA? And up to this point, like so many others, I've never heard of physician assistant before. Even though I come from a family of Navy medicine, I didn't know what a PA was. I looked into it further and thought this did seem like a good fit for me. I ended up serving 20 years in the Navy where I did primary care in emergency medicine. And after I retired from the Navy, I went into neurosurgery, which is what I currently practice.
Just a little bit about me and my background. I know, I guess a lot of people, or normally in the virtual shining, I guess people talk about how they got to this point. And really my entry into physician assistant comes from my work in the Navy. It was working as a hospital corpsman. And again, it was just never a consideration. I never even thought of it, would never even know if somebody hadn't suggested it to me. But I joined the Navy so I could finish my undergraduate, and I didn't know what I was going to do with it. But anyway, took that and worked as a PA. And then after I got out, I got licensed to work in California, where I first practiced in the civilian sector as a PA and went right into neurosurgery. And I guess some people ask like why, and it just simply was, I was sort of exploring different fields. I was working in trauma surgery. This was in San Diego, California. And I actually wanted to do orthopedic sports medicine. And I was talking to a group of people, but it was another neurosurgeon who came up to me and suggested neurosurgery, and just thought there's no way. It just seemed too intense. And I wanted something easy, like some knees and shoulders, something very simple. But he convinced me to meet a colleague of his who was a neurosurgeon. The neurosurgeon I initially met, he already had a PA. So he introduced me to one of his friends and kind of hit it off. But I was still a little intimidated, thinking neurosurgery I can't imagine it's going to be a good fit for me. But I took the position, and our negotiation was literally over. We're both wearing scrubs down the doctor's lounge and just probably talked for about 5 minutes. I was, hey, you looking for a job? Yes. I just want to come in on Monday. It's like, sure. That was basically all the negotiation that we had. So started on a Monday, and probably within months, I knew there was nothing I was ever going to do ever again. And it's been 20 years now that I've been doing neurosurgery. So some of the common things that we see in neurosurgery, one of them is something called normal pressure hydrocephalus. So you may have heard of water in the brain, which is hydrocephalus, or you may have heard this like in pediatric patients, but this is something that we see in adult population. So if any of you are ever going to go into primary care, which a lot of you say you're going to do, this is something that comes up that it goes overlooked quite frequently. So this is why I wanted to discuss normal pressure hydrocephalus. So it's just a congenital condition that happens over time where the CSF is not draining properly in the brain. And in this case, what I have, or the patient I'm going to present, is just I have a 62-year-old male who has increased forgetfulness, which seems like the early onset of dementia. And the family brings him in for balance instability because they think it's something wrong with the spine, is why this person's not walking correctly. They're not bringing him in for the dementia. But when I see this patient, one of the things that I find out is they're having urinary incontinence, which for a 62-year-old, especially someone with dementia, it's not that uncommon. So again, it's one of these things that gets overlooked very commonly. So on examination, a lot of times what we'll see is, as where we talked about, decreased mental cognition. And we can evaluate this on what's called a mini mental status exam. It's just a set of 30 questions that we ask. You can look this up online. They're very simple questions that most of the time seem simple, you and I, but for some people, as they get a little older, especially if they're having difficulty with cognition, some of these questions may be difficult to answer, or a lot of it tests memory. So I'm going to see a decreased mental cognition. Other things I might see is gait instability. And we test this by just asking the patient to just walk down the hallway and either have them walk down, or you can try to get them to balance on one foot. There are different tests that we do, but we can check for this gait instability. Now, all of these together, the urinary incontinence, the decreased mental cognition or forgetfulness, the gait instability, is part of what we call a classic triad of symptoms for NPH, or normal pressure hydrocephalus. So when you see somebody with these three things, you should automatically be thinking normal pressure hydrocephalus. And the only test is to get a head CT. This is the only way to test if somebody has this. It's just that, again, unfortunately, it gets commonly overlooked because for an elderly person, and this doesn't have to be 62-year-old, could be a 75-year-old, a 93-year-old. We see this quite often, and often people are misdiagnosed as dementia. So get a CAT scan, which is very quick. CAT scans, not cheap, but they're fast and effective tests. So this is a head CT without contrast. This is the brain. These areas of what we're specifically focused on, these dark areas right here. So the dark is fluid, and what you're looking at here is CSF, or cerebral spinal fluid. These are normal, we're called ventricles. These are the lateral ventricles. You have other ventricles within the brain, but these are the ones that we're mostly focused on. This is normal. They should look, call it like slit-like appearance. They're very narrow, and this is a normal head CT. So you get somebody who has hydrocephalus, this is what their ventricles look like. So all the black, again, this is all CSF, cerebral spinal fluid. And because usually there's either through age process, there could be a cyst, there could be many reasons why in the third and fourth ventricles you have blockage. Just think of it like a home drain that's blocked. And because it's blocked, it's building up all this CSF, but it's not going to cause seizures, and it's something that happens over time. It's not like overnight or in a week's time this develops. It's rather over a long period of time that it just seems a normal progression, especially you're going to see this in an elderly patient. So again, something that gets overlooked. Now, if you were to see somebody that had enlarged lateral ventricles, the first thing you want to do is just refer them to neurosurgery. I mean, this is going to require surgery, but it's a fairly benign surgery if there is such a thing in neurosurgery, but it really is. So the first thing we'll do is do a test. And what we do is we drain the CSF. We're going to put a lumbar drain. We admit the patient for 48 hours. We put a drain into the spine, just like doing a spinal tap, but you put an actual drain and leave it in place. And then over a period of 48 hours, we drain this fluid. Now, the first thing that we'll do is we'll have speech and physical therapy come and evaluate this patient. They'll run through a test before we drain the fluid. They'll check the patient's gait, their instability, and then they'll also check their mental cognition. And then after 48 hours of draining CSF, and there's a rate that we drain it at, we're not going to overdrain them, but after doing this for 48 hours, they'll go back and reevaluate. And it's really remarkable because a person could have this for 10 years. But if you do this test within a day or two, they're back to normal. And it's really impressive to watch people start walking again normally. Their speech is back, their memory is back. And I'm not saying everybody with dementia is suffering from this, but a lot of times this is overlooked and people diagnose this as dementia. So if they're having improvement with the drainage of CSF, we do what's called placement of a ventriculoperitoneal shunt. It's a surgery. It takes maybe about 45 minutes, not very long. It involves putting a catheter into the brain. And because the ventricle in the brain that's clogged, we just divert the fluid. So we put put a catheter into the brain. And then it's connected to another tube that is literally tunneled under the skin and ends in the abdomen where the CSF just drains into the peritoneal space. We're able to control it. We use literally a magnet where there's a valve that'll be underneath the skin, and we can adjust the valve to change the rate of flow. We can increase or decrease the flow based on the patient's response. They said it's about a 45-minute surgery. Patient stays overnight, usually goes home the very next day, and the results are almost immediate. Well, they are immediate. Okay, another condition that we see very similar to this, or at least presents very similar, somebody with a chronic subdural hematoma. So the dura is the covering around the brain. So this is just bleeding under that dura. And this can be usually we see subdurals from trauma, but for a chronic subdural, it's usually an elderly person who's done something very innocuous that, again, it's easily ignored. For example, very commonly when we have a patient that has a chronic subdural, you'll hear something as innocuous as, I bumped my head on a counter, or, I was under the sink and I lifted my head up and hit my head on the counter, or bumped my head into the medicine cabinet on the wall. And it goes ignored. People don't think about this. But in the brain, you have these, we're called bridging vessels. These are veins that go from the brain to the surface of the dura, or to the lining of the dura. As you get older and your brain atrophies, these vessels are under tension, so they tear very easily. That's why, for somebody like yourself, I'm sure people out there are young, it's more traumatic to have a subdural because it takes more force. But in an elderly person, where you have some either atrophy of the brain and these vessels are being tugged on, it can be something small as just bumping their head. But what'll happen is they'll start acting a little confused, again, a little balance instability. And because they're elderly, people just tend to ignore it. So here we have a 73-year-old female who the family tells us that she's having more falls and she's having difficulties, like she can't remember where her keys are, or there's not exactly forgetting names, but just little forgetfulness. So they bring her in wanting to know why she's having the falls. Again, a lot of times people think it's a spine when it's actually the brain. So through history, again, they think it has to be something traumatic, when in fact, a lot of times, especially for elderly, it's something very minor. So maybe I might get a report as something like a bump on the head. And after I do an examination, I'm probably going to discover, again, I'll do the mini mental status exam and realize that this person is having difficulty with short-term memory, or just little things that demonstrate some kind of deficit in their cognition. Again, we're going to check gait and balance. So usually it's just having them walk down the room, down a hallway, and seeing how their balance is, or again, having them stand and, a cerebellar exam where you have them hold their arms out with their eyes closed, or have them lift their leg. There are different ways that you can check for gait and balance, but this is usually positive. So again, looking at a normal head CT, and then when you have somebody that has a chronic subdural, so this area all over here on the left is all chronic blood. And before anybody sends me a message, if you've never looked at imaging, imaging is reversed. So this, sorry, this is the left side, this is the right side. So in case anybody wants to tell me I got the side wrong. All this dark area, this is old blood. So new blood, and maybe next time I'll do one with some trauma. If you're looking at a head CT and somebody who's just been involved in something chronic, or I mean, sorry, acute, blood will appear as white as, this is all the bone. So blood will appear this white. When it's dark like this, now this is not blood in here, this is CSF, but this is all blood, but because it's dark, this is all just old blood. It's compressing on the brain. Now, this is, again, this is something that happens over time. So again, it's something that goes unnoticed because usually, sorry, is there a question? Do you see it?
No, the person's hand has been up for a while. Like
Oh,
when you said like, oh, can you raise your hand if you could hear us?
got
But
it.
if anyone
Sorry.
has any questions, you could just raise your hand.
Okay, sorry. Yeah, I'm just going to go through these. We'll have time for some questions after I'm finished. I've only got one more case, and I promise I won't take up all that time. But anyway, so this dark area is the blood. What happens is it's compressing on the brain. Now, here's what we call a midline. We measure, when we're looking at the brain, we start right up here, falx, and go down to this area here. We'll draw a line, and if you start seeing the brain shifting over past this line, consider this the middle. So if they're shifting, or we call it a midline shift, that's usually when the patients will present. They're having some difficulty again with memory, maybe it's balance. This blood here is not going to reabsorb. I mean, it could. I shouldn't say it's not. It could, and it usually takes a very, very, very long time. And for a lot of people, if we notice this, let's say on just you happen to scan somebody for whatever reason and you saw blood like this, as long as they were neurologically intact, we wouldn't do anything. We just leave it alone and watch the person, make sure it doesn't progress. But if they're having difficulties, or as you see this midline shift, it's probably time to think about doing surgery to evacuate this. Over time, this will become somewhat solid, and not to gross anybody out, but it has the consistency of grape jelly, and it actually looks like grape jelly when you take it out. It's kind of cool, but it will, if it becomes consistent, it turns into somewhat of a membrane, and you just can't, it won't reabsorb. So you'll need to do surgery. And surgery for this, there are two different ways you could do surgery. So talked about treatment is, if you did get somebody's scan and it did demonstrate chronic subdural hematoma, again, need to refer them to neurosurgery. People who fall with these, the trouble with the falling is they're more likely to hit their head again, and this is going to bleed again and become worse. So if they're at the point where they're having falls and they don't know why they're falling, this is the time to get them evaluated, maybe a scan, and as well as a referral. If it does need surgery, two ways that we can do what's called a burr hole, which is just drilling a big hole through the skull, and we drill two holes, and then we stick a catheter in there, and we just flush lots of irrigation in, as the blood will just come right out. Other ways we'll do is just simple open surgery. If we're not able to get this clot out because it's too thick, just take a big piece of the bone and cut it off about the size of my hand, take off the bone flap, remove the blood clot, and then just plate the bone flap back in place, sew the scalp up, and people go home relatively soon after this. Sometimes they don't even need to go to rehab. Sometimes people do need skilled nursing or rehab after surgery, but often they do go home with just family supporting them. Okay, so the last one I want to talk about is cervical spinal stenosis. And all of these are things that in primary care, in just family medicine, you will see patients who have these things, but they often present as it's age related. Okay, in cervical spinal stenosis, what's happening here is you have a narrowing of the spinal canal where the cord is going through in the neck. And this could be for various reasons. It could be the discs have degenerated down. You have thickening of the ligament that's holding the vertebrae in place. It could have disc herniation. It could just be age related as the spine starts to collapse. There are many reasons why this happens, but again, very similar presentation. Now, you're not going to have confusion or forgetfulness, but they are definitely going to have balance instability. And a lot of times there's also urinary incontinence. So people come in, it's like, oh, I'm having balance instability. And again, they do think it's a spine, which in this case it is. But a lot of times I think it's the lower back, which is interesting because I have patients referred to us for lower back because they're not walking properly. But the first thing we do is somebody's not walking, check the neck. So
James,
yeah,
there's one question. Do you want to wait till the end or do you want to answer it?
I mean, what is the question? I guess?
It's a kind of a general question. Jessica asked, what are some tasks you were able to perform in the OR as a PA?
Oh, okay. If I can do that after I'm finished with the case studies, I'm on the last one and I'll get through it quick. Okay, so 58-year-old female increased unexplained falls. And this was actually my mother. So she was having a lot of falls. And I have a sister who's an OBGYN, and my sister even the same thing. She wanted to check my mom's lower back, but I was like, no, get a scan of my mom's neck. So a typical thing that patients will say is they're tripping, they don't know why. And the most common thing is they say, it feels like I'm drunk when I walk, when obviously they're not drunk. And if you ever hear that, or if you ask a patient, when you're walking, does it feel like you're drunk? And they're like, yeah, it's exactly what it feels like. You should look at the neck. Now, examine the neck. It's not anything that you're going to feel or palpate. It's something that you'll have to get an MRI for. You want an MRI, not a CT. But on examination, one of the things that you might see is they're hyperreflexive. So when you check their reflexes, like the patellar reflex, don't stand in front of them. Okay, stand off to the side. You're going to get hit. There's also something called a Hoffman sign, which is just flicking a patient's middle finger, and you'll see the thumb flex. That's also that's a sign of an upper motor neuron disorder, and also usually indicates that the patient's what we call myelopathic. Myelopathic is just simply the spinal cord is being severely impacted. So here's a cervical spine, and here is the spinal cord. And on either side, the white is CSF. Now you get down to here, these areas, you can see the discs have bulged out, and this one's like touching right up against the cord. This one is actually what we call indenting the cord. You can see the cord curving right here. And I don't know if you can tell in this picture, I apologize, but there's like a really faded white area right here. And that shows that that's like scarring on the spinal cord. That's what we call myelopathy, or that's when a patient becomes hyperreflexive. And if you see something like that, they need to be taken care of right away. Looking at a different view, this is like if you're standing above the patient looking down. So the dark area, this is the spinal cord that we're looking at here. And the white ring around it, this is CSF. That's what a spinal cord should look like. Okay, that's normal CSF spinal cord. So here, if you can make it out, this is the spinal cord, this dark area down here, but you really cannot see the CSF signal. It means it's extremely tight in there. And when it is that tight, it is going to affect the patient's balance as well as their urinary function. Most important is the balance, because somebody that has this kind of disease going on in their neck, if they were to take another fall, jerk their neck or hit their head, very likely this could rupture even further and then just pinch off the cord, and they become paraplegic or quadriplegic. So anybody that's coming in, maybe if you like I said in primary care and they're talking about how they're having falls, they feel like they're walking drunk, this is somebody that I would refer to neurosurgery right away. If they are hyperreflexive, which is they're myelopathic, I'd actually put them in a hard cervical collar. You're not going to like it, but it's not as bad as being paralyzed. And unfortunately, I've seen throughout my 20 years, I've seen a number of people who waited too long and they had a fall, and all of a sudden they're now quadriplegic, and they can't be reversed. I mean, everybody knows that. So treatment for this is surgery. It's either coming in through the front, where we do what's called a fusion, or we come in through the back and do posterior decompression, open up the back of the spinal, open up the back, just taking down the posterior spinous processes and the lamina, opening up so that there's room for the spinal cord to decompress it so that there's no more pressure. And just like I said, if left untreated, If the patient is falling, unfortunately, they keep falling, it's just going to get worse. And either they become to the point where they're weak and they're losing neurological function of their extremities, or they get so bad that they fall and end up paraplegic, quadriplegic. Okay, so that was my little case presentation. So I guess if people have questions, that's the next step, right?
Yeah, I could say Jessica's question again. What are some tasks that you're able to perform in the OR as a PA?
Okay, so working in the OR as a PA, I will tell you right now, a lot of it is going to be dependent upon you and how aggressive you are. I mean, most doctors are going to want you to do a lot. So, the typical role is you're suctioning during surgery, providing retraction, and then when the case is over, is suturing the patient up and closing them up. But as a neurosurgery PA, I can do anything from opening the skull, taking the skull flap off to expose the brain for the surgeon to start working on. If we're doing what's called an aneurysm clipping, so a brain aneurysm is a very complex surgery. So as the surgeon is dissecting down, usually I'm retracting parts of the brain so that we can get to where the aneurysm is for him to apply a clip and tie off that aneurysm. In spine surgery, a lot of times we alternate, because if we're putting in, say, screws and rods, typically you're going to do on both sides. So the surgeon may do his side, and then I'll go ahead and do my side. A lot of times we're dissecting at the same time. Maybe he's on one side, I'm on the other side, and we're going down. We start in the spinous process of the spine. You strip the muscle off down to the lamina and expose the area where you're going to actually do your surgery. So a lot of it is dependent upon the surgeon that you're working for. My first surgeon I worked with in neurosurgery, we had to do what's called a brain decompression. So, or decompressive craniectomy is what it's called. You take out a piece of the skull and you leave it off. And back in the old days, we used to, it's going to sound really weird, but we used to put the bone flap into the abdomen. And we were doing this, and my surgeon said to me, say, could you open the abdomen? And I was, sure, hand me a knife. And I started to do my work, and he's like, have you ever done this before? I said, nope. I actually have. I've opened up abdomens before. I just had never put a bone flap into the abdomen. That was the only thing I'd never done. But what you can do is really based upon your surgeon, who you're working with, their comfort level and your abilities and how aggressive you are. If you're just going to sit back and just, I'm going to hold retraction, do suction, suturing, that's probably all you're ever going to do. But I learned, I just start grabbing the instruments. Once I know the person well enough and I know what the next step is, because a lot of times the surgeon is doing something and then the next step requires them to put something down, take up another piece of instrument, and to that task, put that down, go back to the next instrument. I learned when I knew the guy needed the next instrument, I already have it in my hand and I'm already doing the thing that he wants to do next. And then we just work in a nice rhythm that way. If they don't want you to do something, they'll tell you, but speak up. I mean, I've many times, the first time I ever opened up the skull, it was just, I kept bothering my doctors. Like, when do I get a chance? When do I get to open up the skull? And it's like, you really want to do it, don't you? Like, you bet. So he finally let me do it. But, suturing will definitely be your trademark, though, because I mean, the surgeons, they're done with the surgery. They're going to need to go and write notes, write orders, maybe go see the next patient. So if you become proficient in your suturing, and you're really not going to learn it in PA school. I mean, if you know how to suture now, great. You'll learn more in PA school. You'll learn the rest when you become a PA. If you don't know how to suture, that's fine. You'll learn a little bit in PA school, but really, when you learn your technique in terms of suturing, it's going to come from in the OR. And everybody has their differences in how they want you to close, what they want you to close with, what type of suture, whether it's just a simple, you use interrupted, or if you're going to go and run it. And again, there's lots of different types of suturing, but it will become your trademark. And doctors, if you're good, they are going to want to work with you, because sadly, and they'll tell you this, that the patients often gauge the success of the surgery on the way the incision looks afterwards. And a lot of my doctors tell me that they take credit for the suturing, even though I'm the one who did it. Okay. Yeah.
Another question. When you first started neurosurgery, how long did it take you to get fully trained and feel comfortable with your role?
Okay, it took a long time. And actually, it's a great question because, we always hear about this. I love the flexibility of PA profession because I can go to specialty, specialty, specialty. Okay, try to remember whoever you work for and whatever specialty they're in, it took that person years. In neurosurgery, it's a 9-year residency. So when you switch a specialty, I went from family practice ER to neurosurgery. And as much as I did it for 20 years in the Navy and coming out, boy, I didn't know anything about neurosurgery. I'd actually never heard of an MRI. I'd asked somebody what an MRI was. Everyone was talking about MRI, MRI, MRI. So I finally said, what is an MRI? And they looked at me like, I can't believe you have a license. Okay. So they're like, well, let it go. All right, sorry, we don't have MRIs on board a ship. All right. So I'll tell you when it took, first it takes several months to get to the point where the hospitals will allow you privileges. That's just standard anywhere you go. But the day I had my first privileges that I was able to go see the patients on my own, I remember it like it was yesterday. I go into the intensive care unit, see a patient with a head injury, and I call the doctor. I said, okay, this is what the patient's doing. Doctor told me, okay, do this. So I hang up the phone and I did a test on the patient. I call the doctor back. Said, okay, this is what they did. He said, all right, do this. So I hang up the phone, do a test, call the guy back. This went on easily for a half an hour, maybe 45 minutes. Every little step I have to call this guy. And mind you, this is after I have followed him around incessantly for months, watched everything he did, took notes. But when you're on your own and you're doing it yourself, and never is anything ever the same. So I think it took about an hour to see one patient. And I'll always remember, though, my doctor at the end of it saying, I don't care how many times you have to call me as much as you want. I really appreciate that, the doctor I worked with. So I don't know, it probably took me 4 years. I'm seeing patients right away, seeing my own patients in the office. I'm assisting in surgery right away as soon as I had a hospital privileges. I was rounding as soon as I had hospital privileges, which was all within about a 6-month period. But it took years before I actually feel proficient. And here it is now 20 years later. And there's still, I was in surgery about 2 years ago with one of my surgeons, and he's been practicing for 38 years in neurosurgery. And we had something that happened that even he said he'd never seen himself. And it was quite the moment. So it's, any field that you go into, it's going to take you a while before you'll see patients right away. But to get to that point where you're not bothering your doctor every other minute, it's going to take months to a year. And then to get to the point where you really are comfortable with what you're doing, it's going to take years. And then to get to that point where the doctor comes to you and starts asking you questions, asking your advice, then it takes a little bit longer, but you'll get there. And hey, everybody, don't forget Jordan, new acceptance right here. We're talking to a future PA student here. So if you have questions for her, sorry, Jordan, you probably didn't know I was going to say that, but
All good.
like, oh, there go all the questions now. All right. Let's see. If anybody, like, in terms of neurosurgery, I would tell you it's a little demanding in terms of a profession. So compared to others, neurosurgery, you're generally going to be working out of multiple hospitals because that's just how, only the trauma centers have neurosurgery. And in an entire city, I was in San Diego, California, and in San Diego, I was on call, or I was on medical staff at 7 hospitals. And the first neurosurgeon I worked with, he, sadly enough, this guy was a completely trauma-based practice. So we were literally on call every single day. This was 7 hospitals, invariably you're on call at one of them. And I've told some people my first 2 years, or it was 2 years before I had a day off. Literally, no exaggeration, it was 2 years. And only got a day off because I realized the doctor was never going to take a day off. So I had to ask him, like, I just need some time off. But after that doctor, I went to another doctor who'd been practicing a little bit longer, he was only on call at 3 hospitals. It was a little bit more manageable. but you are going to sacrifice a little bit of your time, your life. Now, I often hear people talk about the work-life balance of a PA. I want to be a PA because the work-life balance. And, unfortunately, when I hear that, I really don't feel like you know or understand what it is to be a PA, because I work the same hours. I mean, the doctor gets called at 3 o'clock in the morning because of a head trauma. He doesn't say, oh, well, I can't call James because he's a PA and he's got that work-life balance thing going on. He's going to call me and he's just going to say, be in the OR in 30 minutes. That's all I'm going to hear. And I get up and go. And unfortunately, head injuries only seem to happen in the middle of the night. I don't know what it is. They do not happen at 3 p.m. So it's a bit of a demanding job, and you will give up kind of a little bit of your life. On the other hand, I would not do anything else. I love my time in family practice. I really did. And when I say ER, most of my ER work was on board a ship, because on board a ship, it's either backaches and colds, or it's something traumatic, like somebody got shot or fell down and broke something or whatever. So it's either nothing or everything. Anyway, but when I went into neurosurgery, I just know that this was the right field for me. I mean, everybody has their own right one. It's not like everybody needs to do neurosurgery, but it is a lot of fun. It's very rewarding when you look at the things that you've done, but it's also very hard, because remember, there's a lot of bad things that happen too. I mean, I had a 16-year-old who fell off a skateboard and hit his head on a curb and died. And the doctor wanted me to tell the family, and you're gonna do those things too, which are the not so fun part of the job.
How would you compare your time in family medicine versus neurosurgery now? Would you say family med is more boring, or did you enjoy both?
No, I love family medicine. I mean, I was fortunate because my family medicine was on board a ship, so I know everybody. And you want to talk about like being a small town provider. I mean, I ate lunch with these people. I had dinner with these people. So I knew them very well. My dad was a small town doctor. So my dad, who was family practice, or back in his day, they called them general practitioners. And when I say small, I mean, it was a town of 500 people. So if they couldn't find my dad at his office, they'd literally just come to the house, knock on the door, say, Dr. Kimber, are you here? So I really do enjoy family practice, because you get to know like in neurosurgery, I see somebody and maybe a year and a half goes by and then they go away. And we had a relationship, but it's gone, and it was fun. But family practice, you're seeing them throughout a whole lifetime. So there's good things on both. So, but it's not boring. I would never call family practice boring. You do that and you're going to get somebody interesting come in.
Another question, or someone just said, I don't have patient experience or much job shadowing.
Okay. I mean, patient care experience, these days, like Scribe is really great. And I'm thinking of the ones that are fairly easy to get without going to a lengthy program. Medical assistant, if you don't have, if you're not like a certified medical assistant, there are places like urgent care centers will sometimes hire people without any experience, without having to go through the actual certification, which can be months and expensive. On the other hand, Scribe is a great one that I think is a lot shorter. Phlebotomy is a way to get in to get some quick training. I don't know. I mean, it can vary in terms of price. There are some places that offer advanced, or not advanced, but kind of a condensed EMT programs. Like I know in Los Angeles, they have these 3-week EMT courses, which are not very expensive, and you get some good training right away that would get you into some really good jobs where you're working directly with PAs.
It's an interview question. My question is for Jordan. What was your reason for becoming a PA? So I give my whole why PA?
Oh, you're gonna give that away? You're just gonna,
right?
You worked a long time to put that together.
I know, but that's why.
Go ahead.
Okay. So this is like I'm practicing right now. So
yeah, but now you got lots of people watching you.
Right, thanks everybody. So for me, it went back to when I was in elementary school, and instead of going out for recess and playing with the kids, I would go out into the nurse's office. remember that she would always say, if people left us with a smile on their face, then you know you did something right. So I had to run to the door and watch everybody leave and see if they had a smile on their face. And that's when I knew healthcare was the place for me. When I went into college, I intended on going pre-health, but I wasn't really sure the career path. It wasn't until I went to my advisor and he suggested the career as a PA, a physician assistant. But to be honest, I never really knew what a PA was prior to meeting my advisor. So I began to research the career and I learned how they attend formal training and manage a patient's healthcare. And the more I looked into it, I realized that it was the career that I wanted to pursue. But my best understanding comes from my direct observation of a PA in the emergency room. While I watched her and I shadowed her, what stood out to me was how she had her own patients that she saw independently. I watched how she would collect a history, diagnose her patients, came up with a treatment plan, worked with the doctors, and I began to really see myself in the role as a physician assistant. I have been working as a medical assistant for like 3 years, so that leaves me no doubt that I want to continue as in the career of healthcare, but it showed me how limited my role was. So when patients ask me, oh, I work in pediatrics, so moms would ask me, oh, if my child has an allergic reaction or is sick, how much Benadryl, Tylenol can I give my child? I'm not like certified and qualified to answer those questions. So I see how PAs have that level of responsibility to manage their entire patient's healthcare, and that's why I want to be a PA.
But wait a minute, you don't want to switch specialties? You're not going to talk about the lateral mobility, the flexibility?
No.
Okay. And I guess I forgot to talk about, I guess briefly, I mean, I had it in the intro, but as I mentioned, my father and grandfather, both Navy doctors, and my mother, she wanted me to be a doctor, but just was not, I couldn't see going to medical school for that length of period of time. I did find medicine interesting once I got into it, but as many times as people tried to coax me into going to medical school, I just knew it was never going to happen. So I'd kind of given up onto it until someone introduced me to PA. And I honestly thought it was just a trick to get me to go to medical school. I thought somebody was just trying to call it something different. Like, no, I'm not falling for that. But when I did look into it and I realized the length of the schooling, which like a lot of us, this is why we chose that over the other. I always tell people it just simply, I'm a hands-on learner. I learn better by doing things. And that's why I thought PA was a much better fit for me, because I wanted to go to school for whatever, the brief period of time. So I get enough to know that, to go out there and practice. And then the rest of it, I would learn through a mentor such as the doctor. And that's why PA was a much better fit for me, why I chose PA. Okay, I think there's some other questions.
Yeah. I worked as a physical therapy technician, very hands-on with lots of autonomy. How would you view that as far as experience goes?
I mean, as far as experience goes, it's great. The trouble comes in is if you don't have any experience with a PA, because you're going to need to have that experience to talk about. When you write a letter recommendation, you're going to need to be able to explain that at an interview. It's not that your hours don't count, but you need to at least get some in-person shadowing so you're physically around a PA to talk about that in your observations.
How many hours would you recommend to have for a job shadowing?
Well, I mean, if you're talking about, are we talking about PA shadowing or? Okay, I mean, for PA shadowing, most schools nowadays, we don't really have minimum requirements because of all the pandemic, which is why virtual came about. So I mean, the average person probably has about 10 to 20 hours of shadowing, whether it's virtual or in person. Certainly more is better. And in terms of if you're talking about like work experience hours, that again is variable depending upon the program. It could be anything from no hours. And I did have a student last year who had a total of 153 clinical hours, and he was accepted into a PA program.
Okay. Next one. Do you know of a PA school that accepts registered behavior technician as PCE?
I would say most do. I mean, I've had a couple this year and certainly a few last year. So it's not an uncommon background. But just like with the physical, the PTA person, just you need to have some experience around a PA, whether that's working directly with them. Look, I've had students that, let's see, I had a couple people that are pharmacy technicians that got in this year. Last year, I had 3 that were dental technicians. I think I had 1 dental technician this year. I've had, last year, I had a woman who got in who was an office manager. literally an office manager. And I'm sure if any of you work in a clinic, you know that there's absolutely no clinical role. So a behavioral technician, you certainly have patient interaction. Those hours do count. I don't know of any school that would say no. There's 321 programs. They do change the requirements quite regularly. So I couldn't say that, positively, but I'm pretty sure any school would accept it. But to be competitive, you do need some time with a PA, whether working with them or shadowing.
Okay, next one. Says not a question, but chat is closed. Just wanted to say thank you for the detailed class, for the detailed cases. That's what I came to virtual shadowing for. I learned a lot.
Great, I appreciate that. I didn't know what, as I said, I've never done this before, so we just kind of put it together real quick, but thank you.
Someone said, is going an extra year for PA residency worth it?
Good question. So that's what I actually considered doing when I got out of the Navy. And I had a letter to go to one of the programs at Yale. And it didn't start it was like 6 months down the road, which is why I took the job of the neurosurgeon. I thought, I'll go ahead and give it a try. And if it works out well with him, great, I'll stay here. Otherwise, I'll go to the residency. Well, I canceled the residency. Here's what I'd say the benefits of working with somebody directly versus the residency. The residencies are great. But remember, you're doing it with the MDs. And the MDs are pretty much going to get priority over you. So, you're going to be doing a lot of pre-ops, post-ops. And everybody wants time in the OR. Everybody does. And, I hate to say, but like low personal and totem pole. So you kind of have to fight with the other doctors to get in that OR time. They need it more than you do. So you end up, I think, in my opinion, doing a lot of administrative work. Whereas I went with one doctor, I was his PA, so I'm with him every day in the OR doing everything. He's my private teacher. I'm not having to worry about 8 other people or 10, 15 other people. Maybe I got lucky because the guy I worked with, he loved to teach. He was an excellent teacher. But I will say one of the other great benefits in a residency program, you'll make some money, not much. They will cover a lot of your expenses, living, your malpractice and other things, but the pay you're going to receive is minimal. When I took my role in neurosurgery, it was not very much. The guy and I agreed to a 2-year contract. But this is what I will tell you is I busted my behind. I worked as hard as I possibly could to make myself as invaluable to this guy as possible. And literally to the day, 2 years to the day, I walked into his office and he looked at me and he smiled and he goes, I knew this was coming. And what he meant was it was time to renegotiate the salary. And he also knew if I walk out that door, I have 2 years of experience. I can go work anywhere now. But he will have to go back and hire somebody else and train somebody else. So he just said, how much? What do you want? I said, double. He said, okay. I walked away and said, oh, I should have said triple. I mean, he agreed to double too fast. So working with somebody, I'm not saying that residency programs are bad because they're not. These are very good. If you are thinking cardiothoracic, you need a residency program. I've only run across one group that would take somebody and only somebody that had a lot of surgical experience, but cardiothoracic, you have to go to a residency. But anything else, neuro, orthopedics, urology, any other surgical field, if you want, it's easy to find somebody that will train you right out of school.
I like that question. Next one. What would you suggest for someone who lives in an area where offices still don't allow shadowing due to COVID? My whole PA journey has been pandemic based, so there has been almost no opportunities for shadowing. I have a PA as a mentor, but there was no shadowing as he teaches now.
I mean, again, when it comes to the shadowing, and we're all very understanding when I say I work with a program and I've worked with other programs. We're all very understanding what's going on. And we know that it's very difficult. So it's not, I don't know of any schools that are having major requirements other than say like 10 hours to accept virtual shadowing. And I don't know, I know like last year there were more opportunities than they seem to be this year. I did have, if you can find other shadow, which on social media, there's a lot of virtual shadowing opportunities. Sometimes through these, you can find people who will, even though they're doing virtual, they'll invite people in to come to their practice. I'll just tell people, I mean, I'm in Austin, Texas right now, and unfortunately I cannot, all I do is assistant surgery. And if you're on staff, if you have a badge from one of the hospitals, I will happily take you into surgery anytime, but I can't get anybody in for that. So as far as finding shadowing, I know, try contacting try contacting your state PA associations. Sometimes they have lists of PAs who are available for shadowing. This is why we really encourage you to work with a PA, because if you're working with a PA, you can use some of that as shadowing time, and it's in-person shadowing. You can't beat that. So, I keep saying it over and over again. And honestly, if you think about it, you look about the number of people who apply to PA school, the sheer numbers of people who apply versus the people who get an interview, and then even fewer that get accepted. And, I have one sitting right here who's already, this is her first year. Okay, her first year applying, and she knew there were things that she had to do to make herself competitive, and she went out and did them. It's not going to be just enough to, I've taken this course and I have 8,000 hours of patient care experience. There's a lot that goes into it. And Jordan's not done. I mean, even though she's already been accepted, she has other interviews pending. And at the end of the year, she's literally going to be sitting here deciding which program she wants to go to. But it's a lot of work that she put in to do it. It's not easy. And it comes down to who will do. I know people like, but I live here, I live there. And I had a student last year, I'll just tell you, is a 53-year-old woman who contacted me and said she wanted to be a PA. And she also told me she has a family with kids and she can't move, and there are only 2 schools that she can go to, and she lives basically out in the sticks. But we worked together, and she did. She actually got into both programs that she applied to. And she was an elementary school teacher. It's not somebody who had a medical background, but she did what it took. So when people are like, I live here or live there, or this is not accessible, or this, or I don't know, or I can't find, the problem is there'll be other candidates that will. And it's not well, understand your circumstances, so we'll overlook that. They just don't. So I don't mean to rain on anybody or make it doom and gloom, but there's always a way. There is always a way.
Someone said, thank you so much for all this information. It was very helpful. Do you think you will be doing any more virtual shadowing?
Yeah. So if you don't know, we put this up on, we put this up on our Instagram page. We have a Facebook page. I meant to put the little logo. So if you don't know, just our group is PA Mentor, Physician Assistant Mentor Online. So we have Instagram, Facebook. We're trying to keep up our TikTok. But on our homepage, we do have a page that says virtual shadowing. I plan to start listing them. We'll certainly post them up on the Instagram page. I'm trying to do this every other week. So right now I have an orthopedic PA, I have a hand surgery PA, I have a gastroenterology PA. And if you have any suggestions or have any specialties that you do want to hear from, please either send us a message through Instagram or post it on our page, so that we'll pick one of those specialties out just for you. But yes, we are planning to do this every other week is what we're planning to do.
What's the Instagram handle again? I don't know if you want to type it. I don't know if you can type in the chat, if there is a chat, or if you could share your screen and type it, or the whiteboard.
I think that's our link to our Instagram. It's just pre-PA Mentor, pre-PA Mentor. And that's the same for our Facebook. And then there's links on the Instagram and Facebook. There's links to our website, so you can get to the website from there. And we're going to try to put out certificates. If you don't mind, if you just go to our Instagram page, and there's a post on Instagram for this webinar. If you just go there and leave a comment about how you attended, and just leave your name, and we'll go ahead and email you a certificate of attendance for this virtual shadowing event.
How many PA schools would you recommend to?
So, well, I mean, for the students that we work with,
no, I'm kidding.
Well, there's 321, so yeah, that's only 30. No, most of the students we work with, about 6 to 8 is all we recommend. So the fact is, it's not an odds game, despite anything you've been told or you've read online. It's not the more you apply, the better your odds. I have a student I worked with this year. So last year she applied, she has a GPA at 3.75. She had 18,000 hours as an EMT. She had letters of recommendations from a PA, a doctor, professor. She had shadowing, she had volunteering, she had everything, and she got 0 interviews last year. One of my students this year, she has a 3.01, and it took a lot of work to get her over 3.0. She got to 3.01. We got her statement done, got her letters in, sent her application out. First week of June, she had 2 interviews and she was accepted at both, including her #1 school. Now, the lady with the 3.375, she just had a bad personal statement. So we worked on that this year. She applied and was accepted, but it's not the number of programs that you applied to. Actually, the lady who had the 375 that reapplied this year, she applied to 1 school. She applied to 1 school. Now, I don't recommend that. You know, if you're kind of a gambler and you feel like you want to do it, okay. I did. I applied to 1 school, but back in my day, it was easy to get in PA school. So anyway, 6 to 8 is what we normally recommend. You either have a good application or you don't. So it's not, if I apply to more. Give another example. A student I worked with last year, we told her 6 schools. She got interviewed at, I don't remember how many, but she got accepted into 2 schools out of the 6. Later, she told me she applied to 26 schools. But she was accepted from the original list of 6 that we presented to her. She never heard back from the other 20, or I don't know if she did, maybe she did, but you do not need to apply to like 10, 15, 20. It's not an odds thing. You just either have a good application and they are going to interview you, or you don't have a good application, like the lady with the 375 and 18,000 hours. Well, I appreciate everybody showing up and coming in tonight. Like I said, we'll try to set one up here in a couple of weeks. We already have some other people lined up, so just check our Instagram. Again, leave a comment on the Instagram if there's a specialty you want to hear about, if you want a certificate of attendance for this virtual shadowing. And thanks for attending.
So